thank you very much for joining us at this in this ATI seminar. Again, I'd like to thank the ATI for asking me to moderate this session. And before we start, I'd like to do the land acknowledgement in terms of the University of Alberta. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continue to enrich our vibrant community. And given that I'm moderating from Calgary, I'd also like to acknowledge that the University of Calgary is located on the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. In particular, I'd like to thank Paladin, Astellas, and AstraZeneca for their very generous support of the ATI seminar series. So I'm very delighted to introduce Dr. Marlena Habal. She received her medical degree from the University of Toronto, where she actually is sitting right now, where she completed her internal medicine and cardiology fellowships. She subsequently completed advanced clinical fellowship in heart failure and cardiac transplantation at Columbia University Medical Center, followed by a research fellowship at Columbia Center for Translational Immunology, focusing on the role of T cells in cardiac allograft vasculopathy. She joined the faculty of Columbia in 2018 until 2022, when she was recruited to New York University, where she was able to start a lab and build the desensitization program that she's going to talk about today. Her translational research interests focus on humoral allosensitization, understanding cellular mechanisms, developing novel therapeutic strategies, and defining the response to treatment. So I'd like to invite Dr. Habal to present her seminar on an approach to pre-transplant desensitization therapies. Go ahead, Dr. Habal.
Hi, thank you so much for having me today. Sorry, I'm just going to get started. Yes, thank you so much for having me. I look forward to being able to give this talk, and thank you also to Dr. West, who invited me to after we spoke at ISHLT last year together. So these are my conflicts of interest. I do have a research grant from Bristol Myers Squibb, and since all desensitization therapies are technically off-label, I will be discussing the use of off-label agents. So something that I think we all know about is the fact that preformed antibodies to HLA dramatically limit the donor pool for our patients, largely owing to the risk of hyperacute or early antibody-mediated rejection. I think one of the important things in the thoracic world is that, unlike kidney transplant, we really don't have options for living donation. And in many cases, we don't have an alternative therapy like dialysis. And so, not surprisingly, mortality on the waiting list is extremely high for these patients. But what I really want to point out today is that this markedly underestimates the scope of the problem, because at least in our programs in the US, many of these patients are never even considered or listed for transplant. So just a little bit about clinical context that I think is often forgotten in these talks. The first is that we have to remember that HLA-specific IgG, which is usually the term I use for anti-HLA antibodies, come in a wide range of titers. And that's going to be really relevant when we start thinking about treatment response during desensitization. And the second is that the type of allosensitizing event is likely to be a little bit more important to outcomes than we often perhaps acknowledge. For example, LVAD-related sensitization versus some of the other types of sensitization, potentially most relevantly, the congenital homografts. So if we just think a little bit mechanistically now, what are the cellular sources of our HLA-specific IgG? the one that we often think about are the long-lived plasma cells, the ones that we typically think of as residing in protected bone marrow niches and secreting antibodies potentially for decades on end. But it's important to consider too that B cells, in the context of T cell help, can rapidly differentiate into short-lived antibody secreting cells that also contribute to the circulating HLA antibody or anti-HLA antibody repertoire. So just thinking a little bit, what is the evidence? So if we're thinking about bone marrow plasma cells, this study by Woodall and colleagues, I think nicely shows and highlights the relevance of bone marrow plasma cells to the circulating HLA-specific IgG repertoire. Here, what they did was they collected paired serum and bone marrow aspirates, and they essentially show that the HLA specificities in the circulation for both class 1 and class 2 were paralleled by those found in the bone marrow. And although I think that study is very convincing, what it doesn't define completely is whether or not these are truly long-lived bone marrow plasma cells. And these have been suggested to actually be CD19 negative by work done in a few different labs, but one of them being Onion Lee's lab at Emory. So for that, we really need to turn to the CAR T cells. Anti-CD19 CAR T cells are known to lead to deep depletion of circulating and lymphoid tissue CD19 positive cells, which include your B cells and a good majority of your antibody secreting cells, except for these long-lived plasma cells. And what you see here in this proof of concept study is a patient who had preformed class 1 anti-HLA antibodies. And essentially what you see along this red line and blue line is no change in the mean fluorescence intensity of these antibodies over 2 years, despite undetectable CD19 cells in the circulation. This was recently furthered by Hill and colleagues that added an additional 4 patients, where they further showed that the same was true for class 2, and that there was absolutely no change in these patients' CPRA over the course of 12 months. So collectively, I think these findings highlight the fact that we need to be able to target plasma cells for desensitization. And today I'm just going to briefly go over 3 of the major classes, the first being the proteasome inhibitors, the second, the anti-CD38 monoclonals, and the third, which are sort of the new kids on the block, so to speak, are the bispecific antibodies. So we'll start off with the proteasome inhibitors, and I just wanted to talk a little bit about carfilzomib, which as compared to bortezomib has better in vitro cytotoxicity, has been shown to be clinically superior to bortezomib in relapsing refractory multiple myeloma. But I think it's also important to remember that unlike bortezomib that we characteristically use at largely 1 dose, the effect of carfilzomib is dose dependent, and in myeloma, the range is between 20 and 72 milligrams per meter squared. What we know is that moderate dose carfilzomib is effective at depleting bone marrow cells by about 70% bone marrow plasma cells. I'm not going to get into it too much, but just a little bit about the clinical implications, always remembering that we do have to be careful with these drugs. There is concern for cardiotoxicity, hypertension, kidney disease, and hepatotoxicity, albeit with less neuropathy. I wanted to highlight this study for a few reasons. This was a recent study of carfilzomib-based desensitization in heart transplantation by the Pittsburgh group. This is their clinical protocol here up on the my right-hand side of the screen, I guess yours as well. It combines carfilzomib with plasmapheresis and IVIG. And I just did want to highlight the fact that this is a plasmapheresis-based protocol, which we'll talk a little bit more about later. But one of the notable features I think about this study is that they went a little bit further with their evaluation of the anti-HLA antibodies. And the key points here is that when they used a neat CPRA, the class 1s were significantly reduced, as we've frequently seen in many trials, but there seemed to be minimal impact on class 2. However, when they went on to do titration studies and look at the C1q CPRA, they found that it more accurately reflected changes in higher titer antibodies, including these class 2. From a clinical perspective, if we look at the patients who were transplanted, 5 out of the 6 were supported on an LVAD, and they had excellent 100%, I believe it was 3-year survival. But it's important to also think about the patients who were delisted or died and did not make it to transplant. And again, this was the patient who had a homograft, the renal transplant recipient, hinting at the fact that for some patients, this is just not going to be enough. And sort of going along the line of inadequate responses, I think it's important to also think of potential mechanisms by which plasma cells can be resistant. One of these is that different subsets may have different susceptibilities to, for example, proteasome inhibitors. And again, coming from the same Emory lab, that they've done a really nice job of showing the heterogeneity in the plasma cell population. And I think that sometimes we need to think more about how these differences in cells that we sort of think of as one big subset impact our response to impact the response to treatment. The other important consideration is, though, that proteasomes themselves can undergo adaptations, making them resistant to our drugs. And this collectively highlights the need for being able to target plasma cells through different mechanisms. From that perspective, one of the groups of therapies are the CD38 monoclonals, owing to the fact that CD38 is highly expressed on plasma cells and plasmablasts. The prototype here is really daratumumab, which is a third-line agent used as monotherapy in multiple myeloma, and a first line when it's combined with a proteasome inhibitor. Dara depletes bone marrow plasma cells through a variety of mechanisms, as shown here, including complement-dependent cytotoxicity, cross-link-induced apoptosis, antibody-dependent cellular cytotoxicity, and others. What we know from the preclinical literature is that when daratumumab was used in non-human primates, along with a stem cell mobilizer known as plerixafor, it significantly reduced DSA in these animals. One of the interesting potential offshoots of this therapy is that CD38 is also expressed very highly on NK cells, raising the possibility that it could have potential adjunctive benefits to prevent early AMR. In terms of clinical evidence, this is really at this point, at least in heart and thoracic organ transplantation, at the case report stage. Shown here is a case report by the Cedars group, looking at pre versus post treatment MFIs of HLA antibodies in a highly sensitized patient. There was another case study done by the Duke group that essentially showed when you did plasmapheresis alone, the antibodies actually went up, the CPRA went up, and then when they treated with DARA, it came down again. As to sort of more formal evaluation, there are some ongoing clinical trials, and we'll have to await the results of those. But I did want to highlight something that I think is very important about the anti-CD38 monoclonal antibodies, namely that CD38 is expressed widely on a variety of cell lineages, including regulatory cells, which include your Tregs, your Bregs, and your myeloid suppressor cells. And so the implications of this are not yet fully known. But in the non-human primate model, despite effective desensitization, the animals developed T-cell mediated rejection and DSA rebound. As to the human translation of these hypotheses, well, in ABMR, there have definitely been case reports of TCMR and antibody rebound. And most recently, there's been a case report of steroid-resistant TCMR in an early post-transplant, low immunological risk kidney patient who had been receiving maintenance daratumumab for multiple myeloma. When we think, though, about desensitization, it's a bit different because we have to also think that usually we give these patients depletional induction therapy. And so I think sort of the rules of the game here have yet to be defined. So going to the final final class of plasma cell therapies that I wanted to talk about, these are the bispecific antibodies. And they're really interesting because they essentially redirect your endogenous cytotoxic effector T cells towards your target cell of interest, in this case, the plasma cell. And the sort of prototype in the field right now are the anti-B cell maturation antigen CD3 bispecifics. And here, as you can see, one arm is recruiting the CD3 cell and the other, the plasma cell, allowing the CD3 to redirect its endogenous effects towards your plasma cell. But what's interesting about using BCMA in specific is that if you look at this graph on the right-hand side, essentially the x-axis is the intensity of expression, if you will. And what you can see is that the bone marrow plasma cells are really the only ones that have this high expression of BCMA, suggesting that this type of an approach might be a little bit more specific for the cells that we're most interested in. In terms of the evidence, this recent New England Journal publication of teclistamab, which is the anti-BCMA CD3, showed high efficacy in the setting of refractory multiple myeloma. And there's an ongoing study for desensitization in highly sensitized kidney transplant candidates, from which we'll have to learn a little bit more. But again, there are some considerations. So one of them is that when you looked a little bit more into that New England myeloma paper, the myeloma patients that responded best were those that had higher levels of pro-inflammatory cytokines, raising questions for our more quiescent sensitized patients as to whether we'll see the same type of efficacy. The second is that we will be intentionally inducing T cell activation. And so the question becomes the relevance of that again in the post-transplant alloreactive setting. And the final thing that I think is really important is that, again, this BCMA or B cell maturation antigen is not required for germinal center formation, short-lived plasmablasts, and in general, T-dependent antibody responses. And so although we may get better specificity, it's not going to address the upstream HLA-specific response. And we'll get into that a little bit more in the next few slides. So in essence, is plasma cell targeting sufficient? For that, we need to go back and look again to data from our kidney transplant colleagues. And this was a randomized controlled trial of carfilzomib-based desensitization. And I think there are two key findings in this study. The first is that they compared carfilzomib alone to carfilzomib with plasmapheresis and showed that essentially there was no significant difference between the two groups. And the second, most relevant to us, is that all the antibodies, or at least the immunodominant ones, rebounded within 30 days. So what is driving this antibody rebound? And here I'm just going to provide a little bit of proof of concept data. So we and others have hypothesized that there are two potential mechanisms. One is that there's a problem in the plasma cell compartment, namely that when you reduce the antibody levels, as has been shown in preclinical models, you actually get an increased antibody production by the plasma cells themselves. The second is that it's a failure to constrain alloreactive B cells. And so here I'm just going to highlight a proof of concept case that essentially builds on preclinical data, showing a patient who had rigorous activated B cell and plasmablast proliferation about 4 weeks before a recurrent case of AMR, suggesting the latter mechanism, at least in this case. And so some of our interest is in trying to delineate treatment-resistant B cell subsets. So this concept, which has been nicely shown also by the Duke group in non-human primate studies, I think deserves potentially a pictorial representation. Here shown is that essentially the dogma is that if you deplete your plasma cells, then you need to have some sort of a compensatory response. And in this case, it's your memory B cells in the context of T cell help. So this would raise the question of whether or not a rational approach would just be to deplete your B cells as well. But there are a few problems with this. Firstly, B cell depletion in bone marrow and spleen with most of the agents like rituximab that we standardly use is quite incomplete. And yes, there are some newer drugs that may provide some additional benefit. But B cell depletion also promotes reconstitution in the same way that I suggested the compensation of B cells to reconstitute the plasma cell pool. And what's shown here are serum B cell activating factor levels after a dose of an anti-CD20, and you can see that they markedly increase. I think from that perspective too, it's important to think that both naive and memory HLA-specific B cells may actually be relevant during this reconstitution phase. And perhaps most importantly is that at least in heart transplantation, early B cell depletion may be detrimental. It's important to consider that B cells have antibody independent roles, including regulation. And that was at least one of the hypotheses that had been put forth for the unexpected finding of increased vasculopathy, or at least percent atheromatous volume in CTOT 11, which was a randomized controlled trial of rituximab induction versus placebo. I think it's also interesting in that study to think that there was no difference in the development of de novo DSA between groups. Shown here, I just put a figure from a recent review that shows many of the different mechanisms by which B cells can play a regulatory role. In any case, I say that to sort of get onto emerging strategies that we've been very interested in to complement plasma cell depletion. And this is largely the form of co-stimulation blockade to inhibit the interaction between B cells and T cells in these T-dependent responses. CTLA-4 Ig is abatacept, and it's closely related drug used in transplantation is belatacept. That is essentially just a high avidity version of it, and is perhaps the most widely known and used right now, although other therapies are in the works. So what I wanted to do here was in one slide try and summarize about 2 decades worth of research on co-stimulation blockade in terms of humoral immunity. If we think about the basic science behind all of this, there has been really important work done by Anita Chong's lab and others on co-stimulation blockade, showing that it disrupts the germinal center and reverses DSA responses in mouse models. But consistent with what we've shown thus far today, you need a proteasome inhibitor once plasma cells have seeded the bone marrow and spleen. Thinking translationally, co-stimulation blockade reduces T follicular helper-like cells that are critical for B cell responses in the circulation of patients being treated with CTLA-4 Ig. There was a nice study done in multiple sclerosis called the AFFIRM trial, where they did some translational studies on the side and showed this very nicely. It's also been shown with belatacept. And in vitro, belatacept suppresses TFH memory B cell interactions very effectively. In the preclinical non-human primate setting, the same drug has, in conjunction with a proteasome inhibitor, being used to reduce DSA and prolong survival. So if we get to the clinical setting, co-stimulation blockade has consistently been shown to be superior to calcineurin inhibitors at preventing de novo DSA and better at suppressing preformed DSA. And this really set the stage for our proof of concept case series, where we used belatacept and a proteasome inhibitor to desensitize very highly sensitized patients in heart transplantation. And I sort of want to, for this proof of concept work that we did, just highlight 3 key points. The first is that there was a sequential response to multiple cycles of treatment. Shown here are essentially heat maps of the mean fluorescence intensities, or MFIs, of the antibodies. And as you can see, walking sort of from left to right along both of these class 1 and class 2 plots, there was a marked reduction in the intensity of these antibodies. The second is that, consistent with the kidney studies, where we were able to target C1q binding HLA-specific IgG without the use of plasmapheresis. And in fact, we do not use plasmapheresis in any of our desensitization protocols anymore. And finally, that in contrast to what was shown in the proteasome inhibitor only trials, we were able to suppress rebound for a sizable fraction of the HLA specificities for up to 3 to 6 months while the patient was waiting for transplant. Clinically, I'll just briefly go through these cases. So we were able to increase the likelihood of finding an acceptable donor for all 4 patients. We took a very aggressive approach to transplanting across up to 8 antibodies, 4 of which had been C1q binding prior to desensitization. And at 4 years post-transplant for this case 3, the most highly sensitized patient, they have normal graft function, no DSA, and no CAV. So we continue to use these protocols and adapt them in ongoing iterations and combine them with our translational studies. But it's important to also think that this is not everything, and we have to think out as to what kind of adjuncts may be of benefit. And so I wanted to take just a few minutes to talk about cytokine modulation, the prototype essentially being targeting IL-6, which is a pleiotropic pro-inflammatory cytokine that has really multi-system effects. It's also important to remember that there's 2 forms of the IL-6 receptor. There's a membrane-bound form and a soluble form. It plays really key roles in the adaptive immune response, supporting humoral immunity, promoting TFH and plasmablast differentiation, and augmenting plasmablast and plasma cell survival. It also enhances effector T cells and pro-inflammatory Th17 differentiation. And the relevance of this is that there's potential for synergistic effects of using these IL-6 inhibitors, both for desensitization and potentially for the early post-transplant period. And the latter is actually being studied in a NIH trial right now. I don't have time to really go into it, but there's 2 approaches to targeting IL-6. One is to target the receptor, that's tocilizumab. The other is to target the cytokine itself, and that's clazakizumab. And what I'm going to try to do in this slide is really summarize 3 trials of anti-IL-6 therapies in highly sensitized kidney transplant candidates. So yes, it's definitely a novel response, a novel type of an approach. The second is that it's unique in that it combines pre-transplant desensitization with post-transplant immune modulation. I think that the general thought, based on some of these trials, particularly some of the more recent ones, is that alone, the impact on HLA-specific IgG is likely to be modest. And so the optimal use in conjunction with other strategies remains to be established. But what I want to get at is the fact that therapeutic pathways for our ultra-sensitized patients has still not been defined. And I think importantly, these patients are often our youngest patients, those who have no option for mechanical circulatory support or durable mechanical circulatory support, such as those with homografts or our retransplant candidates. And so this gets to the concept of, are there adjunctive strategies that we can use in addition to desensitization to try and get the patient through transplant? And one of these is the IgG endopeptidase IDAS, which rapidly cleaves basically all your circulating IgG. This was tried in a pilot study and has been further investigated in an ongoing work of sensitized kidney transplant candidates. I think it's important to consider that these patients were probably moderately sensitized, but they were transplanted across a positive T cell flow cross-match. Key points to highlight here, though, is that there was rapid antibody rebound corresponding to IgG reconstitution, and that this was only partly suppressed by post-transplant rituximab and IVIG. And so the question really is, can these types of strategies be used with an aggressive desensitization and post-transplant immunomodulatory protocol for our most highly sensitized patients? And I think that that still remains to be addressed. So I'm just going to shift gears a little bit here to think about how we can put that information into a sort of framework for developing an approach to actually using the drugs. And the considerations that are at least in my mind, are who do we treat and what do we use? How do we define efficacy? What are the considerations for precision-based medicine? And what is the ideal timing for desensitization? And I don't think that there are definitive answers. And I think that there are a lot of variables, both at the center level, the country level, and the individual patient level that need to be considered. So what I want to do is just kind of define a little bit of a framework for at least how I've been thinking about this. So as to who to treat with what, if we think of two patients who have an identical CPRA of 100% when we use a neat titer, but then if we go on to do, say, 1 in 16, the patient on the left still has a CPRA of 100%, while the patient on the right essentially has gone down to a CPRA of 0. And we can keep going up and up and up. So the question is, the patient on the left, do we try some kind of maximal desensitization protocol, or do we just give up and defer altogether? On the other hand, the patient on the right, should we even be desensitizing them, or should we just use some peri-transplant antibody reduction strategy, as has been suggested at some centers, and then really tailor their post-transplant immune modulation? How do we define efficacy? Well, if we define efficacy based on neat CPRA, then by definition, the patient on the left will be defined as a non-responder, while the patient on the right will be defined as an excellent responder. But what if we keep titering out and we show that the patient on the left actually goes from a CPRA of 100 to a CPRA of 0%? I think what I'm trying to get at here is that efficacy does not necessarily equal effectiveness. And this is important because, yes, 1 in 64 titer may be still too high for one to be comfortable transplanting across. But it does suggest that they have actually responded to treatment, and that perhaps additional cycles or a different drug may help them get to a successful transplant as well. So then what about the considerations for tailoring the therapy to the individual? And this is really one of my interests. So if we think about allosensitizing events as each being a unique type of immune exposure, and we combine that with biological variables, then I think it becomes very easy to see that the immune response is going to be markedly heterogeneous. And so this really, I think, puts a call out for basic translational investigations to complement our clinical studies and actually just our clinical treatment protocols. Finally, what is the ideal timing for desensitization? So I can tell you what I ideally like is to have these patients desensitized at least 6 to 12 months before I think that they're going to urgently need transplant. And this gives you time for multiple cycles to escalate intensity. And then we typically use belatacept to prevent rebound, or at least suppress it as much as possible while the patient is waiting for transplant. Acknowledging that, I have patients right now in hospital who are a little bit too ill for that. And so some of these patients need hybrid approaches where you perhaps do 1 to 2 cycles of an upfront regimen, and then you use some sort of peri-transplant antibody reduction or risk mitigation strategy that might include actually a round or 2 of plasmapheresis, and then aggressive post-transplant immune modulation, which for us is usually a 4-drug regimen that includes your standard prednisone, MMF, CNI, along with co-stimulation blockade. And so just in summary, some of the emerging concepts that I hope I've been able to bring forth. The first is that the circulating HLA-specific IgG repertoire comes from multiple different cellular sources. And so by definition, then, we're always going to be limited if we only target one compartment. The second is that where you start matters. Breadth does not equal titer, and so we need to be able to address both of these clinically. The third is that multi-drug strategies are likely to be required. And we're lucky because in transplant, we can repurpose many drugs that have been developed in other fields, and there's certainly no end to the different combinations possible here. And finally, the concept of an emerging role for pleiotropic immunomodulatory strategies that can bridge the pre and post-transplant period. So with that, I'll stop and say thank you. And maybe if there are any questions or discussion, I would certainly enjoy discussing this.
An excellent overview, and gives us a little bit of perspective on what's being done and how much more needs to be done. And it's really interesting to think about this in terms of individualization, and not only looking at the individual patient, but why are they sensitized, and the importance of that. I'm going to invite the audience to ask questions. I see Lori West has her hand up first, or you can, if you're shy, put your question in the chat. Lori, go ahead.
Yeah, do we have, maybe we could stop screen sharing now?
Yes.
That was a terrific talk, Marlena. Thank you so much. That's it's always so lovely to hear you give these presentations, and I'm pleased that you could join us here today. So I've got what you might expect me to ask, and maybe Anne's going to get into this as well. When we think about the framework for desensitization that you presented, and we look at these increasingly powerful drugs that we're using, what about including a systematic measurement of their impact on ABO antibodies, and whether that might open up some pathways to successful transplantation that currently, especially shocking, are the ones that are deferred from transplant completely without actually understanding whether these drugs could give them a potential pathway forward where they might have a favorable HLA situation and a safe ABO incompatible situation. What do you think?
Well, we've talked about this many times, or at least a few times. So yes, I think that is critical. And, again, systematic trials provide an opportunity to create, biorepositories where we can either do it in real time as one of the secondary or exploratory endpoints, or, it's an ongoing biorepository that can be used in the future. So certainly I'm a huge advocate of that.
Thanks. I think Anne's probably got similar questions.
Go ahead, Anne.
Actually, my question is a very practical and boring HLA question. So, well, not boring, but more practical. So this was, again, I echo Lori's compliments. It was a fantastic overview, like whirlwind. I definitely have to go back and watch the recording. I think someone actually asked about that in the chat. There's a YouTube channel actually for ATI, I believe. So maybe one of the ATI smarter people than me can put a link in the chat, because yeah, it was so much to absorb. I'm still processing, but I loved what you talked about with the dilutions and thinking, because I think sometimes to those outside the HLA lab, that idea of a saturated bead isn't obvious. So if we see a bead that's 30,000-40,000 MFI, we know that might dilute out to 1 in 500 or 1 in 1,000 or 1 in 2. Probably not 1 in 2, but it's not equal. At 30,000 MFI is not equal between different patients. And so in your practice or in your experience, is there a threshold that you feel like on the NEAT, say pre-desensitization or post-desensitization, a threshold where you say I am not comfortable with this if the titer is 1 in 16 or 1 in 512 or whatever it might be? How do you approach those? How do you use those titer data in your practice?
Yeah, that's a great question. I was explaining this to my colleagues recently, and I was like, when you see the titer curve and you don't see an L, it's not a good thing. And when you see an L somewhere around 1 in 16, then we're happy. I
call it a hockey stick shape.
Okay,
Yeah.
We're in Canada,
Yeah.
so we can do that. Yes. So I think it also, it really depends on my approach to that depends on how sensitized they are, right? So if I have somebody where I know that 50% of their antibodies, even before treatment, titer down at 1 in 16, those are the ones I'm going to go after. And I'll just say, forget about the other ones. A 50% CPRA is very manageable for me. So that's the route I'll go. Now, if they're all, all not titering out at 1 in 256, then I'll start groaning. And then you really start doing your best, right? To kind of combine. That's when then you combine finding that most matched and most perfect donor, with maybe some milder desensitization for whatever you can get across. And that's actually what I recently did. I had a young patient who had extremely high titer antibodies and graft loss from that within the past year. And, you know, the DQs, I was not going to recross them. And we managed to find her a donor that way. But you still want to bring down some of the other stuff, if for lack of a better term, you know. And so that's kind of been my approach. And I have one right now that's the 50% super high and 50% comes down in 1 in 16. And those 1 in 16, I'm still not super comfortable crossing without desensitizing. So I'll usually do a couple of rounds of desensitization for that.
We
Yeah,
have
I
a-
agree. It's tricky. I think, oh, sorry, no, you go.
No, go ahead, Anne.
I was just going to say the peds heart, especially with homograft history, those are some of the highest MFIs I think that we see. You probably do as well. And those ones don't always budge. Some of them, like, you know, and I think Annette Tambour, I don't know if you showed her heat map of the desensitization in your whirlwind of,
Yes.
yeah, I love that approach because I'll try to put a link to the paper in the chat for anyone who hasn't seen that, because she has the dilutions and then, like, you know, the pre-desensitization versus, you know, whether or not, like, if it was at 1 in 512, did it desensitize or not? That's still not going to be the same for everybody, but I like that. It's a nice visual to think about it, I think. So yeah, I don't know if you incorporate that into your thinking as well.
So, like I say, there's two papers. I think one is where she shows those CPRAs in different titers, and it has this huge, like, 20 patients. I find it fascinating. Then another one is where she did desensitization, but that was plasmapheresis and IVIG. So I have yet to see an antibody that, if I titer out far enough, does not respond to, you know, high dose proteasome inhibitor with co-stimulation blockade and multiple cycles. They may not come down to something that I want to cross, but they usually will come down in titer. I did want to make one quick comment because I realize that I'm here. And I know belatacept is not approved in Canada. I would challenge my Canadian compatriots to consider abatacept, which I believe is approved, and which it's hard for me to, I use Bella not necessarily because I think it's better than abatacept, but because if I have, you know, a 30-year-old sitting in front of me and I'm comfortable using Bella and I know I can get it, it's hard for me to switch and say, I'm going to try this. But I would strongly encourage the consideration of abatacept, you know, or I guess I should call it CTLA-4 IG here. But, you know, I think, and I can tell you that there are some people that are considering that also, especially in pediatrics, because of the EBV black box warning for belatacept in EBV seronegative people, which is not usually a big problem for adults, but it certainly is a big problem in the pediatric world. So that might be a good consideration as well. Just wanted to put that out there.
Great. Before we go to Kieran and then Lori, there is a chat question from Miguel. What MFI values do you accept for the autoantibody panel?
Oh, that's a great question. We don't do an autoantibody panel, so I go in blindly when it comes to that. But it's a great question, and I will defer to one of my to somebody else on this seminar that is probably far more knowledgeable than I am on that topic.
Anybody want to take that?
I could comment on that if you want. We've looked at it a little bit in some Canadian centers, like just first of all to standardize to see, did we get the same results from center to center as a sort of a standardization exercise back in 2019. There are 2 vendors for those kits as well, so likely the thresholds aren't going to be the same. And also the thresholds now don't take into consideration age or disease status or autoimmune diseases, or I think it's going to be a big, it's going to take a lot of data from a lot of centers, a lot of collaboration to come up with this. And I don't think it's going to be a standardized threshold for all patient populations. For example, what if it's a type 1 diabetic? You would expect some autoimmunity if it's versus a, someone with I don't know, a renal disease that's completely different, so I think, and for children versus adults, it probably won't be the same. And for men versus women, it may not be the same. So yeah, lots to do there. It's still definitely in the learning stages, in my opinion.
And I think though that actually gets to another important concept, which is, what is the difference between organs where you may have more lateral, time to wait, and potentially even between, Canada, in Alberta versus New York City, where we have 6 transplant centers within, you can take a bike from one to the other, right? So, I think that these concepts, yes, I would love to think about autoantibodies in all my patients before transplant. And I would love, just like, perhaps you would love to find the ideal HLA match or whatever, but it's just not practical. So I do look forward to seeing much of that data and the data for also the sort of the standardization question that always comes up. So excited to hear more.
Good. Kieran, you had a question?
Yeah, thanks very much for the talk, Marlena. I'm one of the lung transplant physicians here in the lung program, and so we've published our experience, and we and based on kind of the Toronto experience on perioperative desensitization as opposed to, a long time preoperative desensitization. And so we do that kind of in an individualized way where we will give a higher level induction with our HEG to patients who are where we're crossing DSA, and if they have a positive cross match, then we give them plasmapheresis. But we haven't routinely used a B cell, a dedicated B cell agent, certainly not a dedicated plasma cell agent. So I know that the context is different, and that your experience with perioperative desensitization, may be distinct, but I wonder what your thoughts are on that protocol, and whether or not we should be using dedicated B cell therapy, and I'm also curious about your thoughts. You're saying that you guys aren't using plasmapheresis, so whether or not we're never clear about the role of plasmapheresis, because it's always a bit of a nebulous therapy.
So I think there's 2 parts that are really, really interesting there. So after moving to NYU, one of the great things is I've had a chance to work with both heart and lung transplant teams. And we've done exactly that with a couple of cases of the lung patients, in part because I think that the infectious risk has a little bit of a different weight for some of the lung patients than it does for the heart patients. As to the implications of these antibodies in the early post-operative period, I also wonder if there's a little bit of a difference. And I think that is a fascinating question that has yet to be fully defined for many, many different reasons. I do think that there's a role for plasmapheresis in the immediate perioperative period. So to Anne's point, if you're, there's a nice paper by, I think it's the Georgetown group, where they looked at 1.5 volume plasma exchange will bring down a 1 in 16 titer antibody. And so to get you through the OR and potentially once again after the OR, I think that there's a very interesting and good role for plasmapheresis. When I said I don't use it, I mean actually during the desensitization. I think if you're using a proteasome inhibitor, you're using co-stimulation, blockade, B cell therapy, I think it can actually potentially even create more of a rebound phenomenon. So I do not use it in that setting. As to which is better, a peri-transplant strategy versus a pre-transplant desensitization. I like the concept of trying to get at the cells that are causing the problem and actually like sort of delete them, if you will, as much as possible, at least the plasma cells. So that's sort of why I've put the argument forth for this, but there's never been a head-to-head trial. And I think that that's actually a very difficult thing to do, simply because of the fact that patients are so heterogeneous in their response. And we've really not found a way to define cellular heterogeneity in terms of alloreactivity to a point where we could confidently look at two patients and say, these are the same patients, let's try two different strategies. And I think that it's a fascinating question. So that's kind of my long answer to your comment.
Thanks.
We have Lori and then Simon.
Yeah, just a follow-up question, Marlena, the patient population who have indwelling homographs. So the kids who've had homographs placed during early life as a cause of sensitization, and they're still there. And you're trying to, what do you really think is the likelihood that you can ever effectively desensitize a patient who has an indwelling source of sensitization?
Great question. It may also in part depend on the type of source, if you will, like if it's one of the older homografts that hadn't been decellularized versus some of the newer ones where it's probably not so much that driving it as the number of blood transfusions they've gotten. But to specifically address your question about the indwelling, alloreactive material, I think it's basically like the transplant patient who has lost their graft, particularly in heart or lung. I think it's much harder. I don't think it's actually impossible. I'll leave it at that for now.
Okay, thank you.
Simon?
Hi, thank you so much. And I apologize, I haven't been able to listen to the whole talk, so I hope I'm not asking redundant questions. I wanted to comment a little bit on Kieran's question and hear your opinion for that as well, because for me, the approach of just removing the final product without cutting off the supply lines is a somewhat insufficient approach in general. So in my mind, actually, and that extends to the fact that you also have specific B cells that act as antigen presenting cells. So if I don't get rid of those at the time of transplantation, I'm not interrupting the actual process of immune activation against the organ. And so in my mind, it always has to be a combined thing. We often will do plasmapheresis as well, just to protect from the acute situation. But I still think the key approach is to get rid of the producing cells. And yes, if we use anti-CD20 and no bortezomib, nothing that targets the downstream plasma cells, it takes quite a while until we see the success. But in the end, I think it has to be a adapted combination of things that targets the production of the antibodies as well as the actual existing antibodies, and may then go beyond into the downstream activation that results from the antibodies. Curious what you think about that.
So I completely agree. And that's why, at least like I say, for my heart patients, I like to put them all through 2 to 3 rounds of a comprehensive therapy. We use plasma cell reduction, of whichever nature you want to use. And we use co-stimulation blockade instead of an anti-CD20, because we've sort of found that's more effective and it reduces the amount of rebound that we see. As to sort of balancing what Kieran said and the strategy that I use of desensitizing beforehand and recognizing the tenuous respiratory status of some of these patients, one of the questions in my mind is whether or not you can essentially create a hybrid where you do your plasmapheresis protocol immediately before. And again, this is predicated on how high those antibodies are, but at least for these very tenuous lung patients, whether you can do that plasmapheresis, transplant, and then actually use like a peri-transplant desensitization protocol. And we've done this with a few of the lung patients where we've essentially done a round of plasmapheresis, put in the lung, maybe done one more plasmapheresis, they get thymo intra-op, thymo post-op, belatacept day 1. And then if we even see the antibodies hinting at starting to go up, we'll give them a proteasome inhibitor as well.
Kieran?
Yeah, I just wanted to comment on both of your comments. It's a great discussion. So Simon, I agree with you that it's plausible to do that, and there's a rationale for it. What's interesting is both we and Toronto looked at the outcomes of the patients where we pursued that strategy and found them to be equivalent to patients who were not sensitized and who had, conventional IL-2 receptor antagonist induction. So the question is, what are you buying by adding the additional therapy, and what potential additional toxicity could you be generating? We are, I think there is a little bit of a practice of using rituximab in this context, but it's a little more ad hoc, and depending on how worried we are about the risk of AMR in the next 3 to 6 months. So that I think it's an ongoing discussion, but we haven't seen the deleterious effect in either survival or in chronic lung allograft dysfunction to really cement it and justify that there's a gap there. And just, Marlena, to comment on the timing issue, one of the interesting things about our study that distinguished us from Toronto was that we're actually doing post-operative plasmapheresis. We don't do an intraoperative or preoperative round of plasmapheresis, and we still didn't note a downside to doing that. So, and that's been really, really welcomed by a lot of centers at conferences, people that I've spoken to, because the intraoperative pheresis is so complex to administer for the surgeons and anesthesiologists, and there's potentially a bleeding risk with it, and if the patient's on ECMO, it's another complexity to the circuit. So that's just a point of interest that we have not, in our protocol, been using pre-op or using immediate post-op pheresis.
Yeah, and that's the few cases that we've done that too. But I guess I would challenge, why mechanistically then, what does that say about your patient? Why does that work? There has to be a reason that it works and that the antibodies don't come back, right?
You mean for patients who don't get antibody depleting therapy, who don't get B-cell depleting therapy?
Well, I'm not convinced it's B-cell, but who don't get any kind of a cellular immune modulation except for T-cell, right? Because our drugs really are T-cell centric, be it thymo, be it CNIs, even MMF maybe has a little bit of a B-cell effect, but it's not going to have it certainly won't have a plasma cell effect. So I think that mechanistically, to me, the interesting question is, if it's working and it's working so well, then why is it working? What does it tell us about the antibodies? And the cellular sources of those antibodies is the question. And to me, it would sort of shout that in those particular patients that you're looking at highly T-dependent responses without any significant long-lived bone marrow plasma cell contribution, which just to me is a note of caution that I wonder if it's also a dependent population, like whether it's a specific population or a specific type of allosensitizing event that is driving the sensitization in those patients. I don't know, but I just don't have a mechanistic understanding, and that sort of makes my stomach churn sometimes when I can't explain the biology. But I do think, to your point, that it's great, and it's great to see those outcomes.
Great. Thank you so much. This is a great conversation, a great discussion. I think could go on for quite some time. And I'm sure all of us have a lot of questions. As I said, Marlena, we know how to reach you now, so you can't hide from us. Thanks again for an excellent presentation, excellent discussion. Please take a look in the chat box, and just to remind the group that next Wednesday, November 8th, there's a virtual seminar session presented by the winners of the 2023 ATI Summer Studentship Award. The link is in the chat.
Thank you so much for having me.
Thank you. Take care.
Bye.